Hello and welcome. My name is Donna Hayes, and I'm a graduate student here at the Chamberlain College of Nursing. The purpose of this presentation is to give the nurses that provide billable patient care a basic understanding of the required components needed to bill your service. Nurse practitioners, as well as some clinical nurse specialists, are able to provide services to a patient and potentially bill directly to an insurance carrier or Medicare/Medicaid for those services. We will also review where these billable components may live in an electronic medical record that you might be using. Filing a claim requires three things: patient demographics, a date of service, and a clinical visit note with a billable CPT code. Demographic information can serve two purposes. Insurance companies require a specific data set to verify that you have the right patient and it meets HIPAA requirements. This would include the patient's name, address, date of birth, and gender. The Social Security number is not required, although a lot of insurance companies ask for this information, and several electronic medical record vendors still supply a Social Security field in the patient demographic area. Several years ago, the federal government ruled it was illegal to require a Social Security number as a form of identification, but several people are still using this field. Meaningful use also requires specific patient demographic information to be collected. Meaningful Use is an electronic health record incentive program that was launched as part of the American Recovery and Reinvestment Act. The HITECH Act section of the American Recovery and Reinvestment Act establishes financial incentives for the eligible providers who demonstrate the meaningful use of a certified electronic health record. Specific core measures must be performed on a specific number of patients seen during that calendar year. Meaningful Use core requirement number 3 requires that providers complete demographic information including race, gender, and ethnicity on a minimum of 80% of patients that are seen. One of the most important steps is to make sure the patient visit you are documenting is attached to an appointment. The appointment is the key to being able to file a billable visit. The appointment provides the date of service, provider information, and information about the location where the patient was seen. This appointment then links the patient name and demographic information, as well as other clinical encounter documentation. Always remember to create an appointment in the EMR scheduler and then use this appointment to open the correct visit encounter. The date of service, or DOS, as you will see on several communications around billing, is a key element in providing a billable encounter. When filing a claim, specific information is included about the date of service. This includes the place of service and the provider. There are several codes associated with the place of service, such as the specific specialty of the practice and type of location. As an example, you treated the patient in an outpatient clinic or in an emergency room. Different location codes can carry a different reimbursement rate. The good thing about all of this is that your administrator and/or billing staff will have set all of this up for you, and as long as you remember to start your patient visit note from the appointment schedule, all of this information should automatically attach itself to the claim. Aside from making sure the visit is attached to a patient appointment, completing your clinical note accurately and with as much detail as possible will provide you with the greatest financial return. Patient visit notes, encounters, clinical notes, chart notes, the list goes on and on as to what these notes are called. For the purpose of this presentation, I will be using the term patient encounter. The patient encounter provides two things: an accurate reflection of your patient's visit, including clinical findings and evaluations, and it also provides an objective look at the complexity of the patient visit. All of these factors help to determine a chargeable amount or a billing code. What is a billing code? This is a great question. This may be a new term to everyone, so I wanted to take a minute to review billing and procedure codes. Just like a diagnosis code, there is a federal set list of current procedural terminology codes better known as CPT codes. These codes are reviewed, changed, and published every year by the AMA, which is the American Medical Association. The CPT code set, copyright protected by the AMA, describes medical, surgical, and diagnostic services. It's also designed to communicate in a uniform manner information about medical services and procedures among physicians, coders, patients, accreditation organizations, and payers for administrative, financial, and analytical purposes. CPT codes cover every billable procedure a provider could perform. There is a special subset of these codes called Evaluation and Management Codes, better known as E&M codes. An E&M code is used to quantify for billing purposes the time, effort, medical knowledge, complexity, and skill required to diagnose and or treat an illness or an injury. The level of E&M code assigned to a patient visit is supposed to reflect the actual work done by that provider. As an example, if a patient very well known to you came into the office to be evaluated for complaints of a sore throat, your time reviewing the medical history would be shorter than if this was a new patient you had never seen before. E&M codes will reflect this. Another example is a patient with a history of uncontrolled diabetes, hypertension, multiple surgeries for colon cancer, and he comes in with complaints of constipation or diarrhea. This visit will probably require a higher level of complexity and medical decision-making than it would for a 30-year-old with no medical conditions with the same complaints. The E&M code assigned to a patient encounter should take these different types of patient encounters into consideration, and the more complex the patient is, the higher value assigned to the E&M code. Thus, a greater reimbursement value is assigned also. Billing rates for each code are established by each individual organization. Reimbursement rates are negotiated between your organization and each individual insurance carrier you participate with. So there is a difference between a bill rate and a reimbursement rate. A bill rate is what you are charging for your service, and they're typically published so the patients know ahead of time that your bill rate for a healthy patient exam might run between $50 and $75 depending on how much is done. The reimbursement rate is how much the insurance company is actually going to pay you for that visit. Medicare sets an annual fee schedule that's published each year, and it's listed by state. The reimbursement for each CPT code by Medicare can be found in that fee schedule. For more information on fee schedules related to Medicare, you can see their website at cms.gov. For the purposes of today's discussion, we're going to further divide E&M codes into two subsets. We're going to look at new and established outpatient office visits. There are a lot more subsets of E&M codes, and those can be covered in a later class if you decide to pursue further billing and coding. A new patient can generally be summarized as a patient you have not seen or treated in the past 3 years in your practice. This would include you and any of your partners. The codes range from the lowest, 99201, to the highest, 99205. As the codes increase, the complexity associated with the visit increases, and so does the billable rate. So you may have rates that are established, and these are again fictional, that a 99201 may be $50, a 99202 may be $60, and so on and so on. Continuing on from the previous slide, an established patient is any patient that you've actually seen for a billable E&M visit within the last 3 years. Typically, established patients do not take as much time since their past medical history information is already present in your EMR. There already should be a problem list, a medication list, as well as a completed history. Established patient visit codes go from lowest complexity and reimbursement to the highest, just like new patient visit codes. These visit codes begin with a 99211 and progress on up to a 99215. How do you assign an E&M code to your specific patient encounter? This is a great question, and E&M codes take into account three factors: history, physical exam, and medical decision making. I will be further describing these three systems in the next slide. Based on the complexity in each section, a formula, typically displayed in a table format, can be used to determine the correct codes. These tables are available on the CMS website and typically are handed out with coding courses that really break down all of the details related to coding. There are three sections to a billable E&M code. These are the history, physical exam, and medical decision-making sections. The history section actually includes the chief complaint, the history of the present illness, the patient review of systems, and patient medical history, including family history, social history, and medication history. The physical exam section takes into account the depth and complexity of the actual physical exam performed, and medical decision making that looks into the complexity and types of decisions and plans that you're going to make with this patient. There are two basic EMR formats for documenting a clinical visit encounter. A SOAP note combines documentation into four categories: subjective, objective, assessment, and plan. The second is a tabular format, and each area used to determine billing codes is on a separate tab. So as an example, your chief complaint, your history of present illness, your review of systems are all on separate tabs. A SOAP note will combine these. So here is a sample SOAP note format, and you can see the subjective section is actually a narrative that combines the chief complaint, HPI, history, and review of systems into one area. The objective part would be your physical exam, your assessment would be your diagnosis, and then the P would be your plan, which is cut off on this slide. And here's a sample of a tabular EMR format where you can see up at the top your chief complaint, history of present illness, your history tab, review of systems, physical exam, diagnosis are all on individual tabs. So you would have to click between all of them and enter the information separately. Factors that go into determining the E&M code level include what is actually documented in the clinical visit note. As you all know, if it's not documented, you didn't do it. The chief complaint or reason for visit must be identified. From here, the HPI or history of present illness further defines the chief complaint as to the location, quality, severity, duration, timing, associated signs and symptoms, and any other modifying factors. The chief complaint and history of present illness can be combined into the subjective portion of a SOAP note, or it can be listed in separate categories in the EMR. It is really up to your EMR vendor as to how this information is presented. In the chief complaint and HPI section, go back to the history requirement, the first element for billable visits. Following the HPI levels in the previous list, looking at billing, there are two levels of HPI: brief and extended. Brief only addresses 1 to 3 HPI items in the list, and extended addresses at least 4. Brief leads to a lower overall code, and extended leads to a higher code. Hopefully you can start seeing how your documentation can lead to a CPT code being assigned. And again, make sure that whether you do a brief HPI evaluation or an extended HPI evaluation is really based on your judgment and clinical medical necessity. The review of systems is an all-over inventory of the body systems and reported symptoms the patient has. The following are Medicare-recognized body systems: the constitutional, which includes your fever and weight loss, eyes, ENT, cardiovascular, respiratory, gastrointestinal, gastrourinary, musculoskeletal, integumentary, neurological, psychiatric, endocrine, hematologic, and allergy. The review of systems can be documented in the subjective section of a SOAP note, as these items are symptoms reported by the patient. Other EMR vendors will create a new area to document the complete review of systems. For billing, there are two types of review of systems documentation. First is an extended review of a system. This includes all of the systems related to the chief complaint in HPI. If a patient comes in complaining of an earache, you would typically review the constitutional, eyes, ENT, and possibly respiratory systems. This would count as 4 systems. The second is a complete review of systems. This would include a documented review of all 10 organ systems. Which type of review of systems is performed is up to the medical judgment of the provider. The higher level that's documented for review of systems can potentially lead to a higher level of E&M and billing code. The patient family social history section includes the review of 3 areas: past patient medical history, family history, and social history. Collecting and recording the correct patient historical information not only helps guide patient care, but it's required for billing and meaningful use as well. And remember, in the beginning of the presentation, meaningful use can lead to federal stimulus money. Medication reconciliation is the process of verifying the patient's current medication list against the medication list in the patient record. This is an important safety task and should be done at each visit. This medication reconciliation is also a core meaningful use requirement. Another meaningful use core requirement is smoking status. Every patient over the age of 13 needs to have an annual smoking status evaluated and documented in the patient encounter. This is typically done in the social history section. Just like with review of systems, there are 2 levels of patient family social history billing classes. The first is pertinent, at least one documented history item related to the chief complaint. The second is a complete history evaluation, and this includes one specific item from 2 separate history groups related to the chief complaint. So unfortunately, unless your patient is coming in complaining of pulmonary problems, the social history you documented with a smoking cessation may or may not count as a relative family history for billing purposes. Okay, hang in there. You guys are doing great. We just completed the historical section of trying to provide an E&M code to a patient encounter. Remember, the first section is the history section. That includes the chief complaint, HPI, review of systems, and the past family social history section. These can actually be documented in the clinical encounter in different tabs, or they can all be combined into the subjective part of a SOAP notes. But remember, this presentation is to help introduce you to these items so that you know that they exist. When you're ready to provide care and bill for those services, there are plenty of resources, classes, and billing staff that can help guide you. Moving on to the physical exam. There are 2 types of physical exams. Just like with review of systems and HPI, the type of relevant exam is based on the chief complaint and presenting HPI. Physical exams are documented in the objective portion of a SOAP note, or the physical exam area depending on your EMR. Generally, there are 2 types of exams: a general multi-system or a single organ system. The judgment by the examining provider will choose an exam type based on the presenting chief complaint in HPI, along with the associated risk factors determined by assessing the history. The more extensive the exam, the higher level of complexity, leading to a higher level coding. Typically, most general practitioners will choose the general multi-system exam, so I will describe the multi-system exam here in more detail. There are 4 types of multi-system exams: problem-focused, expanded problem-focused, detailed general, and a general comprehensive exam. Each of the 4 types increase in the number of body areas examined and the level of detail assessed in each body area. To master this type of coding knowledge, we'll take an in-depth look into E&M coding as well as practice. Lots and lots of practice. For this presentation, it's important that you're aware that the level of physical exam you perform is based on your clinical judgment and the patient presenting problems and history. A lot of this is common sense as well. You typically would not do a pelvic exam on a healthy 30-year-old female with complaints of an earache. It's not medically necessary. After completing the HPI, Review of Systems, and History sections, you will have an understanding of the type of physical exam you feel is medically necessary. Medical decision-making is the last of the three components used to determine E&M code levels. Typically, this is the assessment and plan portion of the visit note. For the SOAP note, this is the plan section. If you use an EMR that has broken the note into sections, it may be a combination of the diagnosis, order, and follow-up sections. Per the CPT manual, medical decision-making refers to the complexity of establishing a diagnosis and selecting a management plan option. This also takes into consideration the risk of significant complications, morbidity, and mortality associated with the patient's presenting problem. As an example, a patient with no significant medical history presenting with an earache should have a much lower medical decision-making component than a 60-year-old diabetic with hypertension, kidney disease, and presenting with shortness of breath and tingling in his feet. As we have seen, there are several components that go into providing care to a patient and being able to bill for those services. The first step is to have the patient demographics accurate. Second is having a scheduled appointment to begin the visit note from. Third is choosing a procedural code, or an E&M code, to associate with your documented clinical note. This presentation was meant to give you a high-level overview of all of the required elements and how they work together. I know some of you may be a little overwhelmed, but the most important part is to be the nurse that you are. Use your brain to appropriately assess and evaluate your patient. Document your findings according to your billing, EMR vendor, and Medicare guidelines. The rest will fall into place with practice. I highly recommend anyone doing billable visits obtain a CPT codebook approved by the AMA. Rules and regulations are clearly presented along with the CMS guidelines on how to appropriately code your patient encounter. I hope this presentation has given you an insight into the world of coding and documenting an encounter. Due to the legal and ethical nature of accurately coding and billing a patient encounter, this presentation was not in any way meant to provide any guidance or direction on assigning specific codes to specific situations. Have a great day.